Hello and welcome back to Talking Faces. I'm Dr. Raul and I'm joined as always by my co-host Dr. Lee Walker and by our regular guest here, Dr. Toni Burke.
Once again, thank you.
Yeah, so we were with you in Ireland in Kilkenny. Then we were in New York last week, and now we are in Athens. So welcome back, everyone. Thank you so much for joining us. And our topic today is how to avoid complications. I think someone is very keen to speak on this. And over to you, my friend.
I'm not overly keen because it's not a nice subject to talk about, but I think it's an important thing how to avoid, because managing a complication is very different to avoiding, and we really want to avoid all of these complications. I think one of the things that we need to address is, what is a complication? Guys, what do you think?
Well, there's various types of complications, right? There are the ones that we usually focus on are the really scary ones, right? The blindness, necrosis. But in reality, something that is a complication that happens often, I would say, probably a bruise.
Yeah.
Small lump.
Yeah.
Swelling, redness,
asymmetry.
ptosis,
Yes.
with toxin. Yeah, those type of things. I like to class a complication as anything that will make the patient phone the clinic and is causing them a little bit of concern.
That's probably all of them.
Yeah, it depends where you're based, because our patients just phone all the time.
Well, I think it's the same sort of globally. I think if your patient's concerned about something, then they're really gonna call you up. I think we've only got a limited time to discuss this, and if we keep it to the serious complications and how we avoid those.
Scary ones.
The scary ones.
The complications that worry practitioners.
Yeah, and patients if they're fully informed. Yeah. So when we talk about how do we avoid those real serious issues, what do you think the fundamental problem is? Do you think it's anatomy? Do you think it's the technique? And again, do you think it's the product being employed to do the augmentation?
If you chose a number one, I'd probably put technique down as number one. Number two, product, and number three would be anatomy. And I put it in that order because we can control our technique, we can control our product. We can't always control anatomy. We can have an understanding of it, but we can't control it. So things we can control would be option of tools that we have. We've got great choices these days, improved a lot in the last 10 years. Products are phenomenal compared to how they were. And anatomy is what it is.
I disagree to the point where I put anatomy first, because anatomy is going to underpin everything that we do. A complication is based around the anatomy. Okay, if we don't stick the needle inside the vessel, then we're not going
to. It's important to, yes, because both of you are right. So I think it's important to state or to understand that it's multifactorial, right?
Yeah.
Am I correct in saying that? So yes, the anatomy obviously does play a big role, technique, the product, etc. But these things occur due to a series of things.
Yeah.
A series of steps or series of things that can happen.
Okay, so if we extrapolate back on Tony's sort of hierarchy, then that...
In the sense that how can we hopefully avoid complications? So we can obviously know our anatomy, but we're never going to know it, everyone can be slightly different.
So should we just be showing technique first, or choosing the products, or should we, like we did within the training, just go know the anatomy, know the 3D anatomy, the depth, the distribution of those things, and then work our techniques around that? Or do we just stick the needle in because this is a technique which I've been shown to be safer?
No, because it's important to understand that even within the same patient, you will see variations of this anatomy. So even if because it's a numbers game, right? Because even if you know exactly what the percentages are, this is the variation of the facial artery that you're most likely to encounter, that doesn't really mean that your patient will fall in that cohort. But if you adjust your depth to a correct plane, then I think that you are doing something to try and minimize the complication.
Okay, so we're going to agree that anatomy is incredibly variable. The only constant that we're tending to see through the literature is depth. Distribution is not going to help us too much. So now I'm going to focus on the technique. So do you think cannulas are safer than needles?
I know that in the last 10 years, so treatments I was always extremely cautious about, I've become a little bit more comfortable with. Yes, I've been injecting for longer, but it's definitely also because we're now using cannulas way more frequently. It's a common tool that we take out virtually in every single clinic. Now, you can't just compare a needle to a cannula because we all know there's different gauges, there's different lengths. Same with needles, gauges, lengths. So again, you have to choose as safely as you can the right sort of needle for the job, the right cannula for the job. With regards to results, we all know that practitioners can get very similar results using both tools, and depending on the practitioner's experience, again, I think safety comes down to a bit to that practitioner's experience. We know some phenomenal injectors who'll do a nose just predominantly with a needle with incredible results and few complications, and similarly with cannula. So it's very difficult to compare, isn't it?
It varies because you're absolutely right in saying that it's depending on the operator, the skill of the operator. Some people produce amazing results with one tool compared to the other, and that's one of the things we can't argue with results, right? If they're good results. However, if you're thinking of complications, what your original question was, I think a wide bore cannula is less likely to injure a blood vessel if that is what we are trying to avoid.
So we're all advocating the use of cannulas over needles in the majority of
large surface
cases.
areas, yes, definitely.
Okay,
high risk areas.
So what about a 27 or 30 gauge cannula? Where do we stand with those?
I don't use them.
Yeah, we used to, but now we have enough evidence that we know that 27 gauge cannula is as sharp as a needle, and it needs the same amount of force in order to injure a blood vessel as a needle does. So yeah, this is one of these things that with evidence, with experience, we're changing our practices, because we all had 27 gauge cannulas as a standard not so long ago, right? But now we have more information. That's not to say that a 25 gauge cannula or a 22 gauge cannula will never injure a blood vessel, but it's less likely to.
So if we're in agreement though that sort of cannulas are safer than needles, for example, then why isn't cannula use, and I do prefer cannulas, but why do we not always use cannulas and lips, for example?
I think if you're looking at lips with cannulas, you've got to look at quite a few factors. One, they're expensive things to buy, and there's a lot of people are small businesses. The second, the technical challenge with a cannula, especially in the lips, it was always reserved for advanced injectors many years ago. Only advanced injectors could use a cannula.
It takes more of skill, right? It is a little bit of a learning curve to use.
I think the issue with the cannula is the tissue plane that you're in, especially in the lips, because one of the things which is going to happen to you use a cannula in the lips is that a cannula wants to go to the path of least resistance, and that's the wet side or the submucosal side, and it will easily find its way intraoral, and it's very difficult, if you're not aware of this, to end up placing the product inside the mouth. So it's a technical challenge in the lip. And also, I'll add one more thing, a cannula in the lip without a regional block is extremely painful.
For sure.
Yeah, I think it's more painful than a needle.
So you end up being a little bit more invasive, giving them a local anesthetic in order for them to tolerate the cannula.
Exactly. Yeah.
So Lee, what are the, considering you have a significant level of expertise in the perioral area, what are the downsides or the potential negatives of doing a perioral block?
Well, again, I'm going to go with the obvious and saying it's another skill set you need to acquire. It's
but you definitely have that.
Yeah, I do. No,
and you don't do them.
Yeah, I don't do them. I couldn't even tell you how many regional blocks I've done over the years. You will get, I think, one of those things which you don't want to have with anesthetics is that complete lack of feedback from the patient in terms of pain. I think a regional block you will not get that critical feedback on a vascular accident. The other thing, if you're going to use adrenaline in it, then any blanching could be masked. So therefore, you're masking the two symptoms of vascular occlusion throughout the literature, pain and blanching. The other thing is that you get a secondary edema and you lose the lip tonicity. So all of these factors really, I don't like it. And if you don't give a regional block in the correct way, it can be more painful than the actual treatment.
Yes.
And it's not a nice experience for the patient. So I don't use any regional anesthesia. It's another risk factor. Again, lidocaine sensitivity as well. It's another factor you're placing in there that I feel that you don't need to have.
Do you use blocks, Toni?
Yes.
Yes? You block your patients?
I'm not complete blocks, I do just some
Infiltration.
infiltrations, small infiltrations.
Don't you find that creates a bit of edema?
Absolutely, and a high risk of bruising. It certainly is uncomfortable for the patient.
Yeah.
I luckily can find my patients still have some, I'm able to allow them to smile, they can animate. I do tend to find that dentists nearly always inject more local anesthetic than a doctor does. So, the quantity I would be injecting, I'm fairly confident will be much, much lower than what you might inject. So it definitely has its downsides, but the reason I do it is because I actually do love using a cannula for lips, and I find I get good results, and particularly even for those older patients where I feel there's a few areas I might want to reach which may be better reached with a cannula. For them, I will do that.
So at this stage, we're in agreement with anatomy, technique and product is going to help us. If we understand all of those, it will avoid using a cannula, will hopefully avoid some of the complications. Now, if I can pose this question to you both, is there a place for non-reversible fillers within aesthetic medicine? Wow, that's the silence is definitely here, folks.
I've used non-reversible fillers, sort of temporary ones, and I don't think that with the type of technology that we have nowadays, we have fillers that are able to adapt to the same biomechanical properties of every single layer that we're trying to restore or enhance. They're lasting longer and longer. So I am finding it very, very difficult nowadays to justify using those type of products.
Are we including products such as collagen stimulators in this?
Yes, biostimulatory fillers, yeah.
I almost feel like I'm working slightly in reverse here, because I used to use these again 10 years ago, and just as you were saying, because our hyaluronic acid fillers have improved so much and the duration is so good, and the variety of fillers we're given in our little kit allows us to do virtually everything. I have no need. And even previously I used to see products such, in the nose,
Yeah. Well,
being used and now not.
I've probably been practicing a little bit longer than both of you, and I started off with the polylactic acids and the calcium hydroxyapatite, and then the polycaprolactones.
Silicon?
Yeah, and stone and wood and those type of things.
Oil.
And paraffin. And really using all of those, we didn't have the information we have today, and knowing that they're now not reversible, and people really really challenging this, saying sodium thiosulfate you can reverse calcium hydroxide. No, that was for nodules, and they got a reduction in the size of the nodules. For me, again, it's like you, it's a justification. Does the risk really outweigh the benefit with these biostimulating fillers? For me, no, because of the rheological changes within the parameters of the hyaluronic acid fillers we have now. I don't use any non-reversible fillers because of the risk factor.
I also like injecting something that I know how it would behave 1 hour after, 12 hours, and 12 months after. So that's the other thing for me. Like, I don't like to inject something that then the result is depending on how that product or that implant incorporates into my patient's tissues, how it reacts. I don't really like that.
I think your patients with the biostimulatories, they have to buy into that philosophy that you're going to put something in and 6 months later,
it's going to get better.
It's going to keep getting better.
Oh,
so,
wait, you'll see.
So I don't know whether they're classing them as a volumizer or a biostimulator or a combination of both. But for me, about avoiding complications, serious complications, I would suggest very strongly that all injectors use hyaluronic acid, which is reversible, which is amenable to hyaluronidase. I think that is the safety net we have now within aesthetic medicine.
Wow.
I'd agree.
You agree?
So we're in
Close
agreement,
avoidance.
avoidance of serious complications, we use a HA over a non-HA filler. Yeah.
So guys, any other little pearls or any other complications that we can potentially avoid with injectables if we're using HAs? What about the longevity of an HA or choosing an HA for different areas? Are there characteristics that you would take into consideration when doing this?
So I think lots of the problems we've seen with nodule formation, or which I was speaking to Tony a bit earlier about redistribution of product within a tissue plane, is intramuscular injection.
That's what we or a lot of people refer to as migration, right?
Yeah.
So redistribution of product.
So the muscle and the superficial fat redisplaces the filler into different parts of the fat compartment. A lot of these nodules we tend to see are the result of putting too much product in the intramuscular plane, and the filler doesn't have anywhere to go, so it gets concertinaed.
Compartment syndrome?
Yeah, pretty much, yeah. So what I would use in highly mobile tissue is a filler which is designed to move along with those repetitive sort of intrinsic movements of the face, and that's the reason why I use the fillers which I do. I don't tend to see this sort of clumping together and this sort of palpability of these nodules within those tissue planes. So it's a little bit more forgiving. So again, choosing your rheology wisely and the tissue plane. So it's almost like this custom fit rheology for each tissue layer. You can place the thicker stuff deep down in the deep fat compartment on the periosteum. I don't think we're seeing issues with because they're not subject to those same forces as the superficial layers.
By the way, let us know if you want us to do an episode on rheology, because I think it would be really interesting. So I'm a geek. Lee will find it really interesting, but would that be of interest to you? Toni Burke, final words.
So I think we had some interesting points there with regards to avoiding complications. So we came to agreement that in general, cannulas tend to be safer than needles. Also about placement of your product and choosing your product can help avoid a lot of complications. And hopefully this can be followed up with your knowledge of rheology at a further time.
So I think HA over non-HA, and my final tip is pressure. The severity of any major problem within the face when it comes to using fillers is down to pressure. So my biggest tip to avoid complications, especially intravascular complications, is a very slow, low pressure injection.
And
Volume.
And volume.
Volume.
the last thing I'll add as well is something that might be very, very trivial, but it is just taking enough time to do a formal medical consultation with your patient. If you take enough time, not just assessing their aesthetic needs, but also taking a formal medical history from your patient, I think you will get a lot of information from that might help you avoid complications in the future. Well, with that, I think we'll say goodbye to you guys. Please like this video if you enjoyed it, and subscribe to our channel. And please comments down below. Let us know what you'd like to hear from us. And also, Lee, where can people find you?
They can find me right here at Lee Walker _Academy on Instagram and Facebook. Tony, where can the people find you?
Well, I can be found at Cosmedocs. That is Cosmedocs on Instagram and on Facebook.
And you can find me on Instagram, and not very active on Facebook, Dr. Cetto, DRCETTO. And thank you so much for joining us, and goodbye from Athens.
Goodbye.